anything too inflammatory.
So he found the salem. He got the how did he catch it?
He had like a little Tupperware thing and like found a baby one.
Oh.
I know. So all of a sudden I get this text is like, welcome to our new family member.
You know, they are surprisingly, my mother developed a relationship with a gecko in Florida, to the point where this gecko would watch her swim. If she would catch flies for it, like in the pool, and she would feed it, and whenever she put them beside the pool, the little thing would come out and eat it. I swear they developed like a relationship there for a while. It was really interesting.
I think BF Skinner would have a lot to say about that.
There was definitely some conditioning that happened. It was cute, but it was pretty adorable there for a while. We called her the gecko whisperer.
Is it one of those ones with like the red?
Yes.
Yeah, they're so cool.
Exactly.
Yeah, that's very cool.
But I would get nice little text messages about, you know, look what the gecko did today, and it was quite cute.
He ended up, it wasn't doing well in its little container while they were waiting to go get a habitat for it. So he was like, I can't save it. It's not doing well. I must return it. So he bravely brought it back to the creek.
Back to the wild.
Mm-hmm. Yeah. Such a loss. So sad.
Sorry for our technical difficulties, Stephanie.
Oh, I get it. We went through this too when we did the Project Parachute chats.
Did you?
Yeah.
It's not a perfect system.
No.
Yep. So we can talk a little bit about our backgrounds. We can start off just chatting a tad. So we're not going to do a formal introduction yet, but I think one of the reasons I wanted to have you on today in particular is because you do have these double credentials in developmental and clinical psychology. Can you just tell us a little bit about that?
Yeah, sure. So I have a PhD from University of Pittsburgh in clinical and developmental psychology. And I really was interested in how people develop and how people sort of get set on these different paths in development along the way. And how can we predict why someone goes down one path versus going down a different path? And also, what can we do to help people early enough? Early intervention has always been a huge motivator of mine. How can we detect things early? How can we find ways to readjust? Because it's so much easier at the beginning than when things are really entrenched and people are in a rut overall. Yeah. So I work as a clinical psychologist, and I do therapy with teenagers and with young adults who have eating disorders and anxiety.
Where did you study?
So for college, I went to Yale University, and it's kind of fun actually because there are numbers of like new young psychologists who have come out of Yale. I think a lot of us chose that college, not just for the awesome singing groups, right? Like we also were really interested in psychology, and it's kind of funny now to see that the president of the university was, you know, who everyone talked about as being the intro to psych easy A Salave.
Right.
Was the nickname at the time, and now he's the president. And so people are doing really interesting things about talking about emotions and emotion regulation and emotional intelligence when we were college students. And then the other big influence was Alan Kasdan, who was head of the Yale Child Study Center and the Conduct Clinic, and I volunteered there and learned all about parenting and parenting behaviors, and would watch these kids while their parents were talking to clinicians in the other room. And it was amazing. And I learned a ton of just this hands-on learning. So it's been cool to hear other people who have had similar experiences. Because of those guys.
When you went off to college, had you planned on being a psychology major?
Yeah.
Did you? You already knew?
Yeah. No, I made the decision to become a psychologist at like 11 or 12.
Wow.
Yeah. I was like, yep, that's it. Picked it. That's what I'm doing.
That was your path.
That was my path.
I got the green light to get started. So
right.
we can kick off the formal part of this conversation.
That sounds great.
Super. I'll start out by introducing myself. I'm Cynthia Bulik. I am a distinguished professor of eating disorders at the University of North Carolina at Chapel Hill, and I'm the principal investigator of EDGI, or the Eating Disorders Genetics Initiative. And welcome today to EDGI Talk. I'm really happy to have Dr. Stephanie Zerwas join us today. I've known Stephanie for, insert the blank here, Stephanie, I don't know how many years, well over 13 years. She knows exactly. And she is a developmental and clinical psychologist. She is the owner and founder of Flourish in Chapel Hill, North Carolina, and also the founder of Project Parachute. So welcome to EDGI Talk, Stephanie.
Thank you so much, Dr. Bulik. I'm so excited to be here.
I think we'll probably call ourselves Cindy and Stephanie from here on in, but that's all good.
Just had to start with the honorific.
Yeah, exactly. Yeah. So this is a really perfect time for you to be on EDGI Talk, because when I opened up the newspaper today, absolutely every article, it seemed, was about kids going back to school, kids going back to college, anxiety, worries, not knowing what the plans are. And I know that one of your specialty areas is really children and young adults. So let's just dive in right there and talk a little bit. We've got these kids, we've got parents, we've got kids going back to college. People are anxious. They don't know what's going on. What are your patients dealing with right now?
I think all of us are dealing with this tremendous amount of uncertainty. And we think about uncertainty as being a cognitive process, right? Like, I'm not certain, is this happening or is this happening? But in some ways, uncertainty is also an emotional experience. You know, you can have a worry about something like, hey, where's my car? Where did I park my car? And like, you know, your car is there, but you can also feel deeply uncertain about it. And so people usually do whatever they can to avoid or escape uncertainty. We really love to make plans, and then I'm certain because I've predicted everything that's going to happen. And it's really hard to make those plans right now. And so people are having to develop this new relationship with this thing called uncertainty, where they just notice it, they label it, and they don't try to fool themselves that they have full control over every part of their lives. And that is a really tough place to be right now.
How are you addressing it? Do you have some hints or tips that you're giving people to make this big adjustment?
Yeah, well, the interesting thing is, I think that this means that we have to practice communicating in such a more deliberate and strategic way with the people around us. We're so used to relying on sort of assumptions or heuristics to be able to say like, oh, I keep myself safe, but like that's, you do you, I do me. Suddenly you doing you affects me. And so having that conversation, I work with a lot of college students and, you know, they're living in apartments, and having that conversation with the fellow people in their apartment. Hey, if you go to that party, like you're putting me at risk. And how do we set up expectations or ground rules or have open dialogue about that risk? And it means people are having to level up in their communication skills in a brand new way. And really talk about their feelings and how unnerved they might feel about this risk.
That's really interesting, because it's also tough for people who are conflict avoidant. You know, and I think about that sometimes with like anxious anxious kids who are going back to school who are anxious. It's like if someone in their environment or their fraternity or sorority or dorm or whatever is behaving in a way that could be dangerous to them and to other people,
Right.
you know, how did they get over that get the activation energy to say, hey, I'm really concerned about the fact that you're not wearing a mask when you go into the dining hall or something. You know,
Right.
talk about that for a minute.
Yeah. I do a lot of DBT in my clinical practice, and
So
so
cognitive behavioral therapy.
dialectical behavior.
Dialectical. I didn't hear the D. Dialectical behavior.
Yeah. So a lot of dialectical behavior therapy is teaching that assertiveness, right? I'm not going to wait and pretend like it's all fine and then get really aggressive because you didn't listen.
Right.
I have to find ways of speaking my truth and saying what my needs are earlier. And it's combined with this both and. On the one hand, I feel this way and I don't judge you, but I need you to know that I feel this way. And can we negotiate? Can we come up with a compromise? Or just simply state like this isn't going to work if you're, off at the fraternity party and I'm desperately worried about my loved one with an immune condition at home.
Right. Yeah, it really is an unusual time for people this age to have to be thinking so collectively.
Mm-hmm.
You know, because it is a time in development when people do tend to be a little bit more focused on themselves. But right now, that's actually not good enough.
Yeah.
Yeah.
It's definitely a big challenge. I think in some ways too, we have to have a lot of empathy for what college students are going through right now. There's such a narrative and such a story around, hey, listen, high school might suck, but you put your head down and you get to college and it's all worthwhile. And like the promised land is coming. Just wait till college. College is coming. Like college is going to be great. And now they're like, wait, I've been promised this my whole life. I sacrificed. I did everything I could to go to college. And now college looks like this. Like, this isn't what I signed up for. This is what I sacrificed for.
Yeah.
So it's, especially the incoming freshmen, the sophomores I talked to, they had a little taste of it. And they're like, yes, right. I love this.
And then they got pulled away again, right? Yeah.
They got yanked.
Yep. Yeah. Just another on a pile of losses that everyone is dealing with at this point.
Yeah. So I definitely empathize that this is hard, but at the same time, we're all kind of dealing with those reality slaps, right?
That's exactly that's what they feel like. Yep.
Yeah. And these harsh truths, and we do no one any favors if we pretend like it's like it was last fall, because it's just not.
It's not.
No. Nothing's the same.
Stephanie, I know you worked with us for a long time and still do, and you do a lot of work with people with eating disorders. And is there anything in particular that they're really struggling with at this point too?
Initially, one of the things that I heard from patients with eating disorders is that the food environment had changed so dramatically. They might have relied on restaurants or other sorts of things to not have like a ton of food at home, or they were really worried about food waste. And all of a sudden, pandemic shopping looked way different, and people were buying things in bulk. There was just a lot of food in the kitchen. And so learning how to manage that and manage like all of my favorite things are here, and that urge to binge could be really high, was definitely a concern. There's some positives here though too. One thing I've heard from families who are doing family-based therapy is that having everyone at home makes doing FBT so much easier, right? You can provide that accountability and that supervision, especially in the first phase of the disorder or the treatment. And so it's been really helpful for families to have all of this family time and this reemergence of the family meal as the center of the day, right? You don't have all the different practices or other things that are distracting from that family meal. So that has also been of use.
And that's really interesting because, we just published this study. It just came out a couple of days ago in the International Journal of Eating Disorders. And, we saw the exact same things. People said that people who had bulimia and binge eating disorder, they were at increased risk of binge eating because of all the stockpiled foods. And then people who had anorexia felt like they were restricting more because there was like less accountability if they were living alone. But we gave them the opportunity to talk about the positives, which ended up being a really interesting part of the study because they said some of the same things. It's like having family around and, being able to actually spend time with people and not rushing from one thing to another. Mm-hmm. It helped people sort of like reevaluating with almost what their values were.
Yes.
And that got integrated into their sort of recovery process.
Yeah. I think there's another piece here in the fact that coronavirus is making people think about their mortality in new ways. It's in everyone's faces that we're dealing with something that's potentially lethal. Yeah. And it's sort of making people say, wait a second, like if this is this one precious life that I have, if tomorrow is not a guarantee, what do I want to do with my time? Like, how do I want to spend it? How do I want to, do I want to continue carrying this eating disorder with me? And it's really made people think about and sort of lifted that, like, oh, I got plenty of time, because we see all the time that, that people are surprised that we don't necessarily have the time that we think we have. And I know that sounds really dark, but it's also really...
I think it sounds quite bright, actually. I mean, that's in some ways a ray of sunshine. I hadn't heard people talk about that before in relation to recovery. I've heard people talk about it in terms of, working at home going, this isn't so bad. I wouldn't mind continuing my life like this and not having to commute, 45 minutes every morning and afternoon, that whole reevaluation process. Yeah. But it's the first time I've heard someone talk about it in terms of being a boost for motivating to recover. Mm-hmm. Cool.
Yeah, it has been really cool. I think the other thing is some of the initial reports showed that COVID led to pretty severe weight loss, and some people had like a real GI experience with the disease. And so having that sense of, oh, maybe I need to like make sure I'm as fit as I can be. And that might mean restoring weight. Right. So that if I get this disease, I won't be just at risk immediately just because of being underweight.
Well, this is one of the things that I love talking with people who are doing a lot of clinical work, because you can bring these stories to EDGI Talk that, we don't necessarily have time to get when we're doing research with people and they're filling out questionnaires. And the one-on-one is so important. And that, for example, what you just talked about is the exact opposite of what Boris Johnson is doing in the UK, trying to put the whole country on a diet in order to decrease susceptibility to COVID, which is one of the less good public health interventions I've heard in a while. Yeah, deep breath, absolutely.
Well, I think that's been the other thing is that, people have been talking about the pandemic 15 and there's getting all these advertisements through social media. I get targeted with them all the time because I do work in eating disorders. And so you have to really you have to find ways to communicate back to those different social media outlets that I don't want to see this content. And my very favorite thing to do is to mark it as misleading or a scam on Facebook when I get, this magic pill or this special shake. I'm like, nope, not for me. It's misleading. It's a scam. And you can retrain your algorithm that way real quick.
And we should all do that.
Yeah.
To protect ourselves, but also to give that feedback to the powers that control these things. Yeah, exactly.
My favorite is when I get the advertisements about how my genes are going to control what I should be eating too.
Oh.
Yeah. I'm like, oh, they really targeted me.
What a segue into talking about genetics. Stephanie, you were involved in our previous study, the Anorexia Nervosa Genetics Initiative, or ANDI, right? Where we basically was totally focused on anorexia nervosa. And, we had this really interesting finding that anorexia definitely had a strong genetic component, but B, that genetic component wasn't just psychiatric, it was also metabolic, and we were really talking about a metabolic component to the illness. Given that you're seeing patients during so much of your day, how does genetics come into clinical practice? How do you use that kind of information about the biology of eating disorders to help patients build their own narratives about their illness and their recovery?
Yeah. I can't tell you how empowering it can be when presented, the right way. I think oftentimes we think of genetics as destiny, and we think like, oh, if I have a genetic risk, then why even try? Because I got this risk factor. And so really helping people understand what genetic risk is and what their vulnerabilities are without having sort of and that writes the whole story of your illness, of course, and your recovery is really important. But when you do that, people often feel this great sense of relief of, oh my gosh, it's not my fault. Like, I don't have to feel guilty. I don't have to feel ashamed that I did this to myself, which is something that I hear so often when they're starting to seek out recovery. Or sometimes it's just a recurring thought. And then they realize, wait, no, I didn't do this to myself. Like, it was just a really crappy combination of a lot of factors that all happened at exactly the right time. And then I got stuck in this spot. So that's a really important point. That definitely comes up. I think the other thing that comes up, though, is it's so easy to have sort of this race mentality or benchmark yourself on the person next to you. Like, well, she gets to go on this diet. She gets to do this thing. She gets to play around with food. Why can't I do it? Come on. Like, it's fine. It's fine, right? Like, I saw this person on Instagram. They're fine. Let me do it. I get to do that too. And discussing with somebody, hey, listen, you've talked about how eating disorders run in your family, that your aunt struggled with anorexia. Your grandmother maybe had OCD, and we'll talk about that. Helps them understand, wait, maybe it's not fine for me. Like someone else might be able to flirt with this, somebody else might be able to try something out, and it leaves them unscarred. And you came to the world with certain risks. And that can be really helpful just to contextualize why each person is unique. And we've really got to personalize what you do to you. We can't just give a broad brush strokes about, this is fine for everybody.
I think about that a lot in the context of trying alcohol as well.
Mm-hmm.
People who come from really dense families where they might have people with alcohol dependence in multiple generations and both genders or more genders. And it's like, this just might be too risky for you. You can't afford to go out and, go on a bender or, have 5 drinks in a night, because that could it's almost like awaking the sleeping giant. If you do have this genetic predisposition, why poke it?
Yeah. I find that I end up talking about that a lot with pot use and weed, because I think, definitely it's becoming legal in so many states, and it's sort of becoming normalized, like, oh, it can't hurt you. And then I really talk with someone, okay, you've got a history of schizophrenia in your family, or you've got this uncle or this cousin who's had a psychotic break. And so, yes, your friends might be unscathed by weed, or find it to be helpful in their life to some degree, right?
Yeah.
But at the same time, you're in a different category through no fault of your own, but you've got to listen to your own body and your own biology.
Yeah. It's your biological legacy.
Yeah.
Your family's biological legacy that you carry around with you.
Yeah. And usually they'll be like, huh, that's interesting. I don't really believe you though. And then they go and research it and they're like, oh wait, she's onto something.
Don't you hate it when those psychologists are right?
Oh man. Especially ones who learned more about the genetics. And I think that's been really interesting, is show how, having genetic risk intersects with environmental factors. Yeah.
And it's always both, and I think that's the message that we always try to get across on EDGI Talks as well, is it's not just one or the other. Genes and environment are just so interdigitated that we can't really pull them apart all the time. So
it's so interesting how our brains love the either or, and they really struggle with the both and.
Yeah.
Like the either or feels right, and the both and feels like, what do you mean? That's super mushy. But I think all of us are in this place of like just tolerating the both and right now, right? It's the best of times and worst of times.
And all bound up in one. Exactly. We're going to turn the corner a little bit and talk a tad about access to care. And the reason this is important to me right now, a couple of reasons actually. One is that on one of our Instagram feed at EDGI Study, so at EDGI Study, we just started a self-care module. So I encourage everybody to go up and take a look at that, especially now when we all need to take time for self-care. But also with the current unemployment statistics, we're seeing a lot of people in our COVID study, and I'm sure it's getting even worse, whose family members are losing jobs, who are losing jobs themselves, who are facing financial challenges that they haven't faced in the past. And unfortunately, in this country, that also means losing access to insurance and healthcare. And just wanted to chat a little bit about access to care, and if you have any thoughts for people who really don't have the resources to get formal care right now.
Yeah, and I think one thing that I hear from folks is even if you have insurance and you have what you feel like is good insurance, when it comes to mental health care, that insurance sort of falls apart. And so I think one thing that we really have to work on advocating for is true mental health parity. We have it in name only, where physical health and mental health are treated the same. But when it comes down to the brass tacks, we just don't have that in our country at all. And so I often encourage folks who say like, oh, I've got great insurance, but I can't find a therapist who's in network. Like, what's up with that? To really then go back to their insurer and say like, hey, are you not paying therapists if they don't want to join your network? Like it's not just that the therapists aren't joining that network just it's because they're kind of being encouraged not to through reimbursement through that company. Right. And so as much as you can advocate with your insurance company, I encourage people to do it and really there have been some interesting legal cases that have demonstrated the fact that mental health and physical health were being treated differently. So yeah, so we've got a ways to go there. I also always encourage people, if you can't find somebody who is in network, and I know I'm starting with insurance, which was not your question, but if you can't find somebody who is in network, talk to your insurer or talk to somebody who's out of network about getting a single case agreement. People don't know about single case agreements frequently. And it's a really good option where all of a sudden someone who's an out of network expert, who, let's say in exposure and response prevention, which you need for OCD treatment, you can go to your insurer and say like, listen, there you have no ERP people in your network and I need this. So let's find somebody who you can, I treat like, just like they're a copay. And that's really important.
Right.
Yeah.
So advocate on your own behalf to get the care that you need.
Yeah.
And I'm also hearing, don't take the first no as the final no.
Exactly.
Right?
Yeah. So the other piece is that, listen, no one gets into mental health care because we're really just all about like not helping people. Like we get into mental health care because we really care about our fellow man and we want to do the right thing. And I would say that we're having trouble meeting the demand nationally for people who need care or looking for care. So there's one network called Open Path Collective where people who are therapists will advertise that they're willing to do sliding scale work with folks, or also sometimes free session, totally pro bono for people who are in desperate financial situations. So an open path is nationwide. It's a clearinghouse of all sorts of different therapists who are signing up to provide pro bono care. Everyone's virtual these days.
Oh, that's terrific. Good point.
Yeah. So in the past, it would have been, you know, face to face. You would have found somebody in your town. Now you can find somebody in your state. Yeah, because everyone's online. Yeah, which has actually been a really exciting development, because it means that people in rural parts of the state can suddenly access really solid providers. And so that's another way to go about it, is through those virtual sorts of avenues, and seeking out Open Path Collective. If you are an essential worker, coronavirus online therapies popped up at exactly the same time Project Parachute popped up. And it has a sliding scale. People around the country, therapists around the country, I think their network is 3,500 therapists, have signed up to either provide pro bono care, or they slide up to $50 a session for anyone who's doing essential work right now. And then Project Parachute.
I was going to say, let's go right into Project. Where did that come from? What is it? What is it? Let everybody hear what it is, and then where did the light bulb?
How the heck did that happen? So Project Parachute is a network of 600 therapists around the country who understood that the COVID pandemic was going to uniquely impact healthcare workers. Healthcare workers are facing increased risk. I mean, if I looked at a graph the other day, like they have one of the highest risk profiles in terms of being the potential for infection. And they're also facing just a really uncertain time. I think the other piece is, initially, we didn't know how to treat this disease, right? So it can make people feel really incompetent, and not like they're not really quite sure how to help their patient. And nobody loves feeling incompetent. So they were facing really unique challenges. And the culture of medicine is one that really encourages stoicism and not talking about vulnerabilities. And so having a therapist who can support them through this time and help them deal with the trauma of medical work is really important. And they are critical to all of our well-being. So, you know, they rushed right in, they went to work for all of us, and we've gone to work for them as therapists. So yeah, we've matched 350 people nationwide with pro bono therapists. And just the stories we hear, like I never thought I was going to talk to a therapist. Like I never thought that this would be something I needed. And yet I started to feel really depressed, and I was having trouble sleeping, and I wasn't sure how to get through it. And I really have appreciated having somebody to bounce this off of. So it's been a journey. This was just supposed to be a little thing locally. It was supposed to be a tiny little effort. And I think one of the reasons I had the idea for it came from UNC and from the Taking Care of Our Own program at UNC. And so Samantha Meltzer-Brody started Taking Care of Our Own, and Nadia Chargia is the director now. And it was really devoted to helping physicians, helping residents, helping healthcare workers with their self-care and with their mental state, even before the pandemic started. Because healthcare workers have been at risk for burnout for a long time, and we've seen increased prevalence of suicide in healthcare. And so Taking Care of Our Own was totally positioned to jump right in. At the same time, there are plenty of people who are not at UNC hospitals that don't have that resource in their backyard. And I sort of reached out to Nadia and said, hey, do you think other people would want something like Taking Care of Our Own for, you know, a local private pediatrician's practice or for somebody who might be a respiratory therapist in a different setting? And she said, absolutely. And within 4 days, we had 90 therapists locally sign up who were like, yes, sign me up. Where's my patient? I need a patient. Like, who am I helping? Just like the urge to rush in was so great. And then I had people in other states approach me. Emily Pizetsky from Minnesota said, hey, what are you doing? Wait, can we do this here? And I said, sure. And then she helped me get in touch with Shiri, who's at Elios Health. It's a telehealth intelligence company. And they built a website for us in a couple days. They were like, yes, we will do this, and we'll just rapidly get it up and running. And like just within 2 weeks, we had just a huge network of volunteers. And it was kind of like building an airplane mid-flight, like while you're in the air, like hurtling towards the ground. So it's been awesome.
It's a beautiful story. I mean, everybody's so proud of what you've done, but I also think it just illustrates what you said earlier about how people in mental health go into mental health care because we do care about fellow people.
Yeah.
And that just shows how, we might not, a psychologist might not be able to go and do respiratory therapy or hook someone up to a ventilator, but by golly, we want to help, Yeah. And I think that's what you're seing. So
it was also really cool to see that other people had the same idea. Like it was like that, there are 3 different organizations that all at the same time were like, let's do this. And
do this, yeah.
Independent was an idea that needed to like be brought into the world.
Well, we are grateful. Everyone is grateful. It's an amazing, amazing organization, and
I can't say enough good things about our volunteers. They have been, a lot of them are clinical psychology graduate students who couldn't be therapists themselves and are like, I want to do something.
Right.
And so we have graduate students, interns from all over the country. We have some people who just heard about us and found us and joined, or actually in practice right now. It's our volunteer pool. They blow me away. Like they're so awesome.
So people can find out about it. Just Google Project Parachute and you'll be there.
Mm-hmm. Yep. And all on social media, we're COVID Parachute.
COVID Parachute. Got it.
And I called it Project Parachute thinking that everyone would get the name, but it was really to soften the emotional landing of COVID.
Right.
Yeah.
I like that. I actually said that to my husband today when I was explaining what it is. I said, it's softening the landing. That's awesome.
Yep. We're softening the landing. We can't stop people from landing, but we're softening.
But you can soften it. Absolutely. All right. There's one other thing that I just wanted to talk about a little bit, and that is EDGI. Since that's where we're here today. And so that's the Eating Disorders Genetics Initiative, which is sort of like V2 of Angie. And as you know, we're broadening out not just to look at anorexia, but also broadening out to bulimia and binge eating disorder. And, simple question, what does it mean to you that we're broadening out now to look at the rest of the eating disorders?
Well, I think one thing that I hear from folks sometimes is like, do we really need this? Like, we're ready to do this for anorexia kind of thing. Like, right? What do we really need to know? Like, aren't eating disorders just like one entity? And I think we really know that that's not the case, right? That these are distinct disorders, distinct conditions that deserve their own unique attention. And so I'm really excited that we're going to get to look at all of them. I think there's oftentimes concern within eating disorders, like, oh, it's sort of like, why does anorexia get all the attention? Or why does like bulimia get all the, right? Like, but there's like this sense of hierarchy within the eating disorder. And we know as clinicians and as researchers that each of these disorders can be life destroying, that there's really no hierarchy amongst them. So I am really excited to like learn what you find out from this. It's just the fact that there's a genetic correlation between OCD and anorexia. Like we talk about that in my clinical work all the time. People are like, oh, well, I had OCD as a kid and now I'm struggling with this, right?
And now we know why.
And now we know why.
It's so exciting.
Yeah. Or my, oh, my grandma had OCD and now I have anorexia. Well, now, like, they're like, oh, okay. Like, I'm really going to be curious to hear what we find out with binge eating disorder, especially in bulimia. I think it'll be fascinating.
And I think you're right. I think there has been this focus on anorexia. For some reason, if we look historically over the course of how eating disorders research unfolds, everything always starts with anorexia. And I think there is this false belief that it's more dangerous and more life-threatening, or it's just more visible. Mm-hmm. And so it tends to get the money first, and it tends to get the attention first. And then once we prove that, yes, there are real concrete findings there, then we can get more funds to do the other eating disorders. But hopefully EDGI will put an end to that, so that we'll have, no, seriously, though, we'll have like real concrete information. Yeah. My prediction is that we're going to find, some genetic factors that cut across the 3 eating disorders, but then there are also going to be distinct ones that make it clear that these are not the same entities. We're dealing with different disorders. Yeah, there's some similarities, but there's some real differences as well.
Yeah. I think one of the things I often have to explain to people is that we're kind of behind in eating disorders compared to other mental health conditions. And that we're trying to play catch up often. And there are just fewer dollars that are devoted to eating disorder research. And so the fact that we're at this point now is such an incredible gift. And it's going to allow us to go farther, faster.
Right.
Yeah.
Yep. We're working on it.
Yeah.
So if someone is interested in hearing more about EDGI, all you have to do is go up to edgi.org. And please follow us on Instagram and Twitter and Facebook, and the handles for all of those are at EDGI Study, EDGI Study. So please give us a look. Yeah, Stephanie.
People are afraid of hospitals these days, right? Like, yes. Going into the hospital is a scary place. How are you handling it?
Oh,
they have to go to the hospital to get a blood draw?
We don't have to do blood. That's the beauty of EDGI. So with Angie, everybody had to donate a blood sample, but with EDGI, it's so much easier. So all you have to do is you fill out questionnaires online, and then we send you what we call a spit kit, and it comes in the mail, and all you have to do is spit in it, patch it back up and pop it in the post, and it comes back to our lab. And then, of course, everything is done under completely sterile conditions, so we don't have to worry about COVID concerns when it comes to that. But
amazing.
The genetic field just advances so rapidly, and we can do now with saliva what 10 years ago we needed blood to do. So great question.
That's
also brings up another important point in terms of treatment. The other thing we didn't talk about, Stephanie, was online resources and digital resources. Mm-hmm. For people who are afraid to go to treatment, who can't access telehealth. There are some pretty good programs out there, and the one I'm thinking of right now is Recovery Record, which is a great app-based intervention that gives you some basic cognitive behavioral skills for dealing with eating disorders. And I'm not saying it's a be-all, end-all and the only treatment you're ever going to need, but it does give you some handy in-your-pocket skills that you can use if you don't have access to other treatment right now, or to augment the treatment you're getting.
I'm also a huge fan of Woebot, WOEBOT. Woebot is a chat bot that was developed by an eating disorder researcher who now it just provides basic CBT skills. And you really feel like you're chatting with your little robot friend who will walk you through ways to reframe thoughts and think of new ways to do things, introduce you to all sorts of different CBT concepts through YouTube and other videos. Woebot's a awesome little chatbot.
That's great. We will try to put all these things on our Facebook page. So all the stuff that we talked about during EDGI Talk today, we'll make sure we put some links up for so people can check them out later if they want to.
That sounds great.
Stephanie, anything you want to add at the end that we haven't covered about eating disorders or Project Parachute or anything?
Well, self-care, right? You guys have been doing some awesome jobs, like explaining what self-care is, like how to find self-care, how to like make sure you're actually taking care of yourself. I think I kind of want to put in like a plug for boring self-care.
Explain.
So people think of self-care as being the bubble bath or the sort of Parks and Recreation, like treat yourself. Like sometimes it's self-care, cleaning the bathroom and making sure you have a clean environment to like live in and walk into. Sometimes it's important self-care to reply to that email that's been languishing in your inbox that you've been studiously avoiding. Sometimes it's self-care to like send that thank you note to someone because you're expressing your gratitude for them. Like self-care is not just the shiny, happy stuff. It's also facing the things that just are like lingering in the back of your head.
Because removing those things from your I haven't done this yet list is a way of making yourself feel lighter, right?
It is, yeah. But it's also showing up for yourself, right? You're showing up for the fact that you're worth taking care of and these things are worth taking care of.
What a great note to end on. Stephanie, thank you so much for joining us today. And thank you for everything you're doing, for your patients, for everyone around you, and for Project Parachute.
Oh, thank you. Thank you. Thanks for having me. This is super fun.
Take care. Bye. Bye-bye, everyone.
Bye.